Job opportunities in the hospital for families and advantages of AMS certificate. See, advantages of AMS certificate, I can say, see, the stewardship is, evolving. The stewardship criteria and the stewardship need is evolving day by day, and it is huge, right? The resistance patterns are emerging, the bacterias are evolving, right? And it is not about we don't have enough medicines, but it is so speedy process that we need to update ourselves related to this matter. While our subject curriculum and our course curriculum doesn't have lots of things related to this, we are we need to have those 6 years or 4 years related to our, that should be focused on the basic learning. So that is the need of certificate and certification courses related to the AMS, antimicrobial stewardship. So you can show it while, to the recruiters, to the interviewers, that you must be, aware of this term. You know how to solve these queries and how to deal with resistant strains. You know how to read antibiogram. You know that what is MDR, XDR, and PDR infections, how to deal with it, what are the, therapies. So to show them, to educate yourself, the certification program is important. And the job opportunities for the families in the hospital, I will be very honest here, the clinical pharmacist profile, okay, it is not as steady as it should be in the, Indian hospital things, right? Because when we are comparing the CP post, the Indian scenario and the abroad scenario, this is the vast difference. Why? Because there CP itself is aware of their own roles and responsibilities. It is very huge and it is critical as well, right? Pharmacist intervention plays a immense role, I will say, in the ADR management, managing complex therapies, medication management, right? So TDM also they are doing. So lots of things are there which they are doing there, and we are not able to do it here. Somewhere the lack is very huge, okay, and somewhere there is also problem with the knowledge of pharmacist, and somewhere there is also a problem related to the opportunities we are getting, both equally, right? So I will be very honest here that we don't have a large and a huge market for the clinical pharmacist post. I will not give you any kind of false hope, but you can be see this, you can see this gap as an opportunity to build something. Okay, I am not saying this particularly the lack of opportunity, and that I am not saying is as a challenge, but I am seeing it as an opportunity for people like us who are eager to participate, right? So you can make a difference by learning a lot of things, and by having the awareness of the roles and responsibility a clinical pharmacist is holding. So you can imagine that after passing a 6 year, or after graduating from the bachelor degree, okay, after taking the bachelor degree in the pharma, what intern or what a student is expecting, they are not industry ready, they are not hospital ready, right? Because what they know is only the reference books and the guidelines and all, but what exactly the clinical setting is demanding is different, right? Demands are different. No one is going to ask you what is written in the DP Rose algorithm, okay? No, but this is also mandatory to make your base very clear. But lots of things we need to build on that base, okay? And for that you need a lot of this certification and all, right? I think we have 50 participants with us. We are good to start. Only the orientation program is done, right? So yes, now I think the modules are this is the module number 2, but the originally the theory will start from today. See, the practice we will be following, I will brief you about first, I will brief you about what will come in the session orally. You need to listen to me carefully, and then I will share my screen with you, okay? And then we will go through by the PowerPoint presentation. Okay. But before that, you must listen to me that what is coming in the session. Once the why is clear in your mind, we will proceed with the PPTs, because I don't want this advanced version of AMS. It is online, right? It is online. So many disadvantages are associated with it. So we have 50 participants with us, but not 50 are listening to me, right? So see, I was also a student at some point. Okay. So I know that what are the the alternative ways, and what are the I can say the other ways of uh, skipping the lectures and all. So I cannot force you all to put your videos on and all, but we can focus on learning. I will ask for the reactions, I will ask for the queries at the end. We need to discuss a lot of things, right? And you must be ready with lots of questions at the end. I will also give you access if you want to speak, to unmute yourself in between, because of we can avoid any type of that glitches and all. For that reason, I'm putting you off. Okay, I don't give you access right now, but at the end, I will give you access to unmute yourself. To if you want to show up, I will give you the access to microphone and videos also and all. Okay, but at the end. But please ask as many as questions if possible, so that lots of perspectives we can cover. Okay, so I think we are good to start. I think we have 53 participants with us. Okay. Again, I will say good evening and welcome back, all of you who joined recently. I hope you are doing well. So, what is coming in the session today? Today's session is title itself with the advanced concept in the antimicrobial stewardship. We will start with good evening, guys. Good evening. I can see your messages coming. So we are starting it, right? So please focus on the what is coming. Okay. Focus on what I'm saying, and I'm briefing you right now, and then I will share my screen. Okay. So don't panic if you don't see anything. Okay. So okay, so we are discussing about what is the title. So title itself has the advanced concept. Okay, advanced concept in the antimicrobial stewardship. We will start today, but first we will be having brief knowledge on the recap. We will, revising that what is the antimicrobial burden, what is the Indian scenarios, what are the challenges on a global level we are having, and then we will be shifting towards the pharmacokinetic and dynamics driven therapy. So this is a 1 hour advanced session I can consider, where we will be briefing, revisiting why this antimicrobial stewardship fails in the real practice, and it is a huge burden. Okay, then slowly we will move into the core pharmacokinetics and dynamic concepts. I hope you guys have the little bit idea about PKPD. Okay, so what body does to the drug, what drug does to the body, we will see those concepts briefly. And also we will see that this PKPD concepts that actually determines the success or the failure of your antimicrobial therapy, how exactly it is being connected, especially in the critically ill patients, I will tell you. Okay, so this is what is coming today. So we will see shifting. Okay, we will see the global burden, and then we will see today some of the challenges as well, and then we will see antimicrobial stewardship in the real practice advanced. Okay, so this is the very first module I will consider, because the orientation only had the brief knowledge about the whole course. Now from today we will be starting the actual concept clarity, and I want you all to be only focused towards the concept clarity and not the theory is already you are learning in your classroom and in your daily settings, right? But here, for what reason we are here? We are here for the concept clarity. You should be able to do a lots of things after the end of the session or after end of this whole 6 month program. Okay, I will be starting the whole the session will be the learning objectives, so it will be clearly guiding you throughout that what is coming in the session, why it is important, why should be very clear in your mind whatever we are discussing. Okay, so just a minute, I'm sharing the screen, give me a minute. And then at the end, we will discuss about your queries, confusions, if you have any. Okay, just a minute. I hope the screen is visible to you. Is it? Okay. Thank you so much for your reply. Thank you. Just a minute. So, guys, if you found any, glitches in the screen or any kind of uh, disturbances in between, feel free to drop the message, okay, in the WhatsApp group as well, so that we can solve it immediately. This is the online platform, so we must be like that. Okay, so we will be having a small recap and then we will be shifting towards advanced concept in the AMS, that is particularly PKPD driven. Okay, so from global challenges to PKPD driven therapy, this is what our title of the module today. I hope it is making sense to you that where exactly we are heading. That should be very clear. Okay, so this will be 1 hour session for the advanced clinical practice, and you must be aware of the fundamental things today, right? So focus on the basic part and not the whole picture. Okay, have the broad mindset to take these things. So let's start with the learning objectives. Why this learning objective? First, I will tell you that what do you mean by learning objective. This is the only module number 2, right? So theoretically it is the first module to gear up our whole 6 month of course. So we will be having total 22 to 25 sessions in our upcoming 6 months, and every session will start with the learning objectives or else why it matters, with the title why it matters, so that you should be able to understand the rationale behind the session. Okay, so learning objective will guide you further that by the end of the session what you will be able to do, okay, by the session, not the whole course. So focus on the learning objective. It is very clearly defined, very, in an understandable way it is defined. So by the end of this particular session, to check the recap and to check the PKPD driven therapy, you will be able to understand why this basic stewardship principles often fails in the real practice. First of all, you will be getting the answer and of the why the stewardship, basic stewardship fails and why the need of advanced version is there. Okay, also with the recap you will be able to understand the very first bullet point. Second learning objective is by the end of the session today, you will be also able to recognize some of the global as well as Indian antimicrobial resistance strain, okay, or the surveillance, I can say, or the trends, I can say, right? So, antimicrobial resistance surveillance on a global level, what is the scenario? What is the Indian scenario? By the end of the session, you will be able to understand. Also, by the end of this session, you will be able to apply some of the advanced PKPD concepts. Okay, not just theoretically, but I will say clinically. That is the main learning objective for the session. Okay, this is the heart of the session, to be able to apply advanced PKPD concepts clinically. And by the end of this session, you will be also able to interpret some of the real patient cases using this PKPD dosing. Okay, so you will be able to interpret further PKPD based case scenarios. So this session is meant to move you from, I can say, guidelines to further decision makings, okay, or particularly bedside decision making. So this is exactly the learning objectives. I hope it is making sense to you, okay, what we are learning today. Now, let's start with the antimicrobial stewardship. A quick recap so that those who didn't join in the basic course have the glimpses of what is stewardship and what is exactly the need behind it. So, antimicrobial stewardship, also it is known as AMS, very popular word. Okay, this is traditionally summarized, I can say, as the four rights. Okay, four right. So for R also you can remember, for right also you can remember. So it is summarized as the four right, the right drug, the right dose, the right route, and the right duration. So that is what it is, the stewardship means. And let me give you a idea about the word stewardship. So stewardship is a careful monitoring, okay? Carefully monitor the use of your antimicrobials. That is antimicrobial stewardship. The meaning of the word to stewardship is very simple, is the carefully monitor something, to use of your antimicrobials. So if the aim is very clear, that is the right drug, right dose, right route, and the right duration. That is the summarization of your AMS. Okay, so practically, this is not possible, guys. Okay, practically all the time to have the right drug with the right dose, right route, right duration, at a right cost, not at possible, but ultimate goal can be this. Okay, we can work towards this particular goal. Okay, so goal is very simple but powerful. You can see the second bullet point here. Goal is very simple but powerful. To maximize your, cure, maximize, we want a maximum cure, minimizing the resistance pattern. Okay, minimizing the resistance, toxicity, and the cost also we need to minimize, right? However, in practice we often focus only on the drug, and we forgot about the dose and the exposure, right? So we must be aware of the dose, we must be aware of the exposure, we must be aware of the bacteria and viruses which are evolving, how they are evolving, what practices we need to adopt. Okay, so these all things combine, you can say it is the AMS. Okay, so this is antimicrobial stewardship. So why basic stewardship fails? Let me just brief you about why this basic stewardship fails and why we need advanced version in it. So despite having guidelines, guys, stewardship often fails in the real practice. Often, I will use the word often here. So this is what happens around us. Why this is happening? Because clinicians are under pressure. Because clinicians are under pressure, there is fear of treatment failure, especially in the cases of ICU and especially in the OPD patients. So they will obviously start with the broad spectrum. Okay, empirical broad spectrum use, because they don't have culture results yet. Okay, and they are not aware of the specific organisms which is causing further the disease. Okay, so they will start with the broad spectrum use, and also treatment failure risk, fear of clinical failure, fear of treatment failure. Okay, some of the inadequate diagnostics, these are the reason behind the broad spectrum antibiotics. So these broad spectrum antibiotics are started empirically and then it is never ever reassessed. That is where exactly clinical pharmacist can play a huge role in the reassessment. Okay, diagnostics are delayed, unavailable. This is also the problem. Most importantly, there is a poor understanding of PK and PD, guys. Poor understanding. The last bullet point you can see here, poor understanding of PKPD is the reason behind this, particularly why this basic stewardship fails. So stewardship becomes, protocol driven and not the patient driven anymore. And when we are talking about in the current, current affairs of pharmacy, if you are following precision therapy, personalized therapy, these are very important words. These are emerging words, right? So we are more focused toward individualized treatment, precision medicine, personalized treatment. But you can understand stewardship, the basic stewardship is protocol driven now. Predefined standards are there. That is the reason why it is failing. It should be patient driven and not the protocol driven. Okay, so these are the reason behind why basic stewardship are failing. Let me just give you idea about ground reality in the clinical practice. So let's look at what actually happens on the ground. Antibiotics are started without culture reports. This is what happening around us. Okay. Once the culture report arrives, de-escalation should be there, but no de-escalation after reports is also happening. Why? Because of failure, treatment failure risk. Okay. Maybe the physician is doing de-escalation further 2 days later, 3 days later, a week later, patient will come again with the same complaint and they will tell that we are not getting any improvement because of your therapy, you are not a good doctor. So that is what the risk is, right? So no de-escalation are happening after reports. Broad spectrum antibiotics patient are taking since many weeks. Also, if you are aware of the idea, if you have idea about the pneumonia cases, guys, guideline is suggesting for the pneumonia that is the 5 to 7 days the treatment, right? But the patient with the pneumonia is taking the same antibiotic doses for more than 10 days, and this is the commonest issue. I will give you the examples in between, lots of examples in between, based on my experiences, so you will also relate with it, right? Check the pneumonia patient in your clinical setting and find me any patient who is taking as per the guideline. No, they are taking more than 10 days, more than 12 days. That's where exactly the resistance will be, producing. So antibiotics are started without culture, no de-escalation happens after the reports. The same antibiotic dose is used for a 50 kg patient, same will be used for the 100 kg patient. So that is same dose for all patient. It should be individualized, right? Then renal dysfunction, sepsis physiology, I will say ICU changes, these are completely ignored. And these are the factors to be considered while, appropriate dosing. And that's where exactly CP is standing. And when we are comparing it, the Indian scenarios and outside India scenarios, they are doing it. They are doing this practice. And that is the reason why the high pay, right? A good pay. So, yes, of course, we need awareness and we need a lot of things to improve. So, we are following stewardship in a name, but not in the pharmacological reality. That is what the ground reality in the clinical practice. And now the focus is being shifted. Okay. As in the orientation itself, I told you that our prime minister is also coming up with this ICMR report and highlighted the issue related to the resistance. So we can be, have the idea that how much big the issue is. So in the near future, obviously the need for this antimicrobial stewardship will be huge. Okay. So I think this ground reality is very important to check to proceed further. What is the importance, right? So now it's time to discuss why this AMR surveillance matters. So I hope why is already clear in our mind, but still we need to discuss antimicrobial resistance, that is also known as AMR. Okay, so this is very popular word. Okay, very popular, or AMR. That surveillance is essential. Surveillance करना बहुत जरूरी है. We need to do a surveillance. Why? Because it tells us in the end which organisms are being resistant in the market, in the community. Okay, which antibiotics are losing the efficacy. For example, azithromycin, you might be aware of the azithromycin, right? Very popular, very important for the throat infections and all. After COVID-19, the efficacy of that particular drug is being declined. Okay, now the people are taking azithromycin, like the Dolo 650, they are taking in the breakfast and not having any effect. Okay, so why this is happening? We need to check. And how we can do it? By the surveillance. Okay, so surveillance is further tells us which organisms are being resistant in the community, which antibiotics are further losing its efficacy, and where stewardship interventions are urgently being required. Okay, so surveillance further guides us to make the policies, to make the guidelines. Okay, but it does not automatically guide individual patient dosing, guys. Surveillance cannot automatically guide further the individual patient dosing, but actually it can helps. It can help to track a lot of things. Okay, so obviously it can guide the treatment policies, it can detect the emerging MDR threats, multi-drug resistance threat, supports the stewardship decisions. That is the reason why we are learning this. Let's understand the global AMR surveillance system. So we already have it. We already have it globally. We rely on the multiple surveillance system, guys. And we have here the, very important is the global antimicrobial resistance and use surveillance system, or the full form is this and the short form is the GLASS. That is GLASS. Global antimicrobial resistance and use surveillance system. This is a GLASS and this is coordinated by the WHO. Okay, World Health Organization. And this is the global AMR surveillance system we are having. Okay, see, before learning to the principles and before diving deep into the theory, you need to be aware of what is exactly in the world right now. Okay, what we already have, and then you can focus on what we don't have right now till date, and then we can focus towards it, and then we can work on that direction. That is the reason we are starting our whole 6-month course with this particular slides that will give you idea about what exactly the world is already having in the term of this AMR, right? So we already have this global antimicrobial resistance and use surveillance system, which is coordinated by the WHO. We already have this EARS net, the European, I will say the full form. If you are noting it down, note it down. The European Antimicrobial Resistance Surveillance Network. European Antimicrobial Resistance Surveillance, that is EARS, and NET is the network. Okay, surveillance network it is, which monitors the resistance trends, across the Europe. So it is basically for the Europe, but we must be aware of the term. And in India, we have this ICMR, AMR network, Indian Council of Medical Research Antimicrobial Resistance Network, or ICMR, AMR network, which collects all the hospital-based resistance data altogether. And this systems further tells us what is happening, worldwide, but not how to, further correct it in a good way, because now it is rising like anything, right? So these are the documentation happening worldwide related to the resistant strains and all, and these are the global AMR surveillance system you must be aware of before jumping into the advanced version of antimicrobial stewardship. Okay, you must be aware of WHO class, you must be aware of the Europe network, and you must be aware of the Indian network, which deals with AMR surveillance. So this is only for your information. Now we must be focused towards the India. So we will discuss about India specific AMR trends. So in India, the AMR burden is particularly high, very high right now. So we see very, high resistance through the fluoroquinolone and many more like beta lactams, ESBL is there, carbapenem resistance is there. We have multi-drug resistant salmonella as well, MDR E. coli, Klebsiella as well. Okay, so we have lots of things in India, and India. These are some of the three bullet points. The first three bullet points are very important, and it is the red area. Okay, and it is the high risk things. Fluoroquinolones. To deal with it, it is very important to understand the doses mechanism of the fluoroquinolone. If you are using beta lactam, we need to check lots of things, right? Because many patients are now extended spectrum beta lactamase resistant, carbapenem resistance. Okay, so lots of things are there. Multi-drug resistance, salmonella, E. coli, Klebsiella is also there. So our major, contributor is this OTC, over the counter antibiotic availability. And you guys will be agree with me with this point, that India is not having so much of guideline of the guidelines we are having, but not a strict guideline for the use of OTC. So every medicine is, antibiotics are also available over the counter, so the misuse is there, overuse is there, and that is the reason behind the resistance is increasing like anything, right? Many antibiotics, fluoroquinolone हो गया या फिर beta lactams, are also over the counter available, which should not be. The label is also there on the tablet, okay, that schedule H drugs, X drugs and all, but it is not practiced, as it should be. So that is one of the reason, and this is the scenario, the Indian scenario. So we must be aware of this thing. What is the practice gap which is driving further the AMR? So let me discuss about it. What is the practice gap we are having? So major practice gap includes, see this bullet points: antibiotic prescribed for the viral infections. These are very important things. Antibiotics for viral infections, which should not be there, okay, which is not for indication. It is not intended. So for the viral infections, we must have antiviral medicines, right? But people are taking it for the, for example, fever, weakness. Those they can consider it like the self doctors they are, right? And they are taking self medications because it is available OTC. Okay, second bullet point is the OTC and the self medications. So, obviously, antibiotic prescribed for the viral infection, self medication, incomplete courses. That is also the reason. Delayed or absent diagnostics. They are not going for the lab reports and all. No culture reports is also the big issue. And most importantly, no dose adjustment in the renal dysfunction or critical illness. No dose adjustment is happening. That is where exactly the gap, in this gap exactly the clinical pharmacist is standing, right? To do these things, to check these things, to do the dose adjustment and all. So resistance is not only about wrong drugs, guys, it is also about wrong exposure, I will say. Okay, wrong exposure, and we need to check it. We need to check it because it is contributing further to the AMR. Okay, antimicrobial resistance. Let me just discuss a mini case for the introduction, and to to have more detailed knowledge on it, we will be having a mini case here. So let's take a simple clinical example here. Imagine a 25-year-old patient, focus on the age, 25-year-old patient with the enteric fever, which is written here, right? He receives ciprofloxacin repeatedly as an outpatient, repeated ciprofloxacin use. So symptoms partially improves but never fully resolved. Why? Because he or she was on self medicine. So this is single example, guys, but this is the scenario which is largely happening in the India. Okay, largely I will repeat, because many patients are there which are not taking the medicines which are not recommended by the patients, not recommended by the pharmacist as well. Okay, so this is how you can relate the things. Also, we have a mini case on the outcome. So let me see this drug. Let me see this case and let me relate it with the drug therapy. So this patient later, present with the severe illness. This patient who is taking a ciprofloxacin repeatedly, partial response was that, but it was further the illness. So what is outcome? Later, the patient further represents with the severe illness. Blood culture, further the test was done, and blood culture shows MDR, that is multi-drug resistant salmonella. Why? Because of frequent ciprofloxacin exposure, right? So it is resistant to the fluoroquinolones. Fluoroquinolone resistant was the case. Culture report shows MDR salmonella. So now stronger, intravenous antibiotics are further required in this case. It requires IV higher, line therapy. So this is the classic example to understand suboptimal exposure, which is further leading to resistance, and the whole selection of the therapy is guiding further driving further the MDR, right? So you need to be aware of these things, and these are the scenarios happening on a huge level, right? On a large level, and people are doing this, and then it is resulting into the resistance strain, and it is driving further towards the MDR. So we need to understand these things. So this is a small recap. Now we will be seeing the lots of things in the upcoming slides, but the key learning from the case, I think it is clear. Repeated suboptimal exposure of the fluoroquinolones, selection of resistant organisms, right? So this is the key learning. Okay, now let me just give you idea about the PK/PD, and the very important word are the pharmacokinetic and dynamics parameters. Why? Because it ultimately guides your therapy. It ultimately guides the therapy, and it gives you idea about what is exactly happening, right? What body is doing with the drug, what drug is doing with the body. So the question is, was the antibiotic wrong? Was the antibiotic wrong, or was the dose, duration, and exposure was wrong? Okay, so stewardship is not just about the drug selection, but it is about dose, timing, and exposure. So this is where exactly this term PK and PD, that is pharmacokinetic and pharmacodynamics, are further comes in, and it becomes the backbone. I will say it is becoming the backbone of effective stewardship, guys. Right. So once we have aim of antimicrobial stewardship, we must be aware of the fundamental things related to the PKPD. When I say fundamental, that means we should be ready with the concept clarity of PKPD mechanisms. Then only you can guide the stewardship principles, right? So let's start with what is PKPD, right? So this is the advanced PKPD concept I will be discussing with you today. So let's start with what is PKPD. Pharmacokinetics, the PK that describes what the body does to the drug. Okay, what body does to the drug. While on the other hand, we have PD that describes what drug does to the body. Okay, what drug does the body means what drug does to the main cause, that can be bacteria, that can be virus, but ultimately the cause, right? So what body does to the drug, that includes whole process like absorption, distribution, metabolism, and excretion. And what body does to the what drug does to the bacteria, ultimately the cause, that describes a whole thing, whole picture, how it is being metabolized and what is the mechanism of action of the particular drug. Okay, and the bridge between this MIC and clinical outcome is very important. So PKPD bridges this laboratory value called the minimum inhibitory concentration, or you can have the idea MIC, with the real patient outcomes, guys. What do you mean by MIC? Minimum inhibitory concentration, which is required to kill the bacteria, okay, to kill the virus. That is minimum inhibitory concentration. And also we have another term with us, that is the maximum safe concentration, MSC, right? And the range between these two, that is known as the therapeutic window, therapeutic index, right? And we might be having idea about the narrow therapeutic index drug as well, okay? So that drugs requires therapeutic drug monitoring, so that will be our separate topic for the discussion. But when I say MIC, you must be clear with the whole picture, okay? So this is very important to understand the PKPD. Okay, let's start with why this PKPD is crucial in the AMS. So without it, without PK and PD, stewardship is incomplete, guys. Because underdosing that leads to further the treatment failure and resistance, while overdosing further leads to toxicity, right? So this PKPD, pharmacokinetic and pharmacodynamics, further, it guides us to improve the survival, especially in the ICU patients. Okay, so it improves the ICU survival rates, and stewardship is no longer about the restriction, but it is about the precision, I will say. So limit resistance development will be achieving. Okay, you can achieve these things by learning the PKPD principles correctly. So it can prevent underdosing, because underdosing will lead to treatment failure. It can reduce toxicity. It can actually improve the ICU survival, and it can limit the resistance development as well. So this is the reason behind the PKPD principles, whatever we are learning. Okay. Now let's focus on three core PKPD, indices, that meaning the concepts. Okay, concepts. So there are three key pharmacokinetic and pharmacodynamic parameters that you need to be aware of to determine the antibiotic efficacy. Okay, very first is this FT, that is the T. Okay, that is the time, that greater than MIC. I will be explaining you one by one what it is in the upcoming slides. Don't worry. Just have a look here, that three core concept you must be clear of, okay, clear about. Then we have second is the Cmax, the maximum concentration to MIC ratio. And the third one is the area under the curve to MIC ratio. Again, that is the AUC and MIC. Okay. And each antibiotic class is depends, I will say, predominantly on one of this. And every antibiotic class is depend on this. And we must be aware of this three terminologies, three parameters to examine the PK and PD. Okay. So let's learn one by one. We will see this first of all. What is this? So I told you that the T is should be greater than the MIC. That is the time dependent killing, guys. Time dependent killing. Okay. So if T is greater than MIC, that means the percentage of the time, please understand, the percentage of the time the free drug concentration remains above the MIC. Okay. The percentage of the time the free drug concentration remains above the MIC, it will be greater than minimum inhibitory concentration, which is required to kill the bacteria, or to have the therapeutic effect of the particular drug. So this concept, this parameter is very crucial for the time dependent antibiotics. Okay, especially I will say beta lactams. Beta lactams में क्या क्या आता है? What it includes? So all type of penicillin, all type of cephalosporin, carbapenem, right? So it applies to beta lactams. It applies to carbapenem. So in ICU patients, we often target more than 100 percentage, more than 100 percentage T greater than MIC. So that is T greater than MIC is the very big concept. Percentage of time the free drug concentration remains above the minimum inhibitory concentration. Minimum inhibitory concentration is also known as minimum effective concentration, guys, which is required to kill the bacteria and to get the therapeutic effect. It should be remain, your the free drug, the time of the free drug concentration should always be greater than the MIC value. Okay, and in ICU patient, we often target this thing, right? More than 100% T should be greater than MIC. So this concept should be clear to you. Next is this, that is, you see, this is the example I have included, and then we will shifting towards the Cmax. So this is the example. So let me just give you example of piperacillin, so that will be better example to fit. Piperacillin tazobactam is given as a short bolus. Okay, short bolus. Drug levels may fall below the MIC before the next dose. You can consider it, right? It is written here in the bullet point. So in the piperacillin tazobactam, which is given as a short bolus, the drug levels may fall below the MIC before the next dose. So by giving the same dose as an extended infusion, we keep levels above the MIC for the longer period of time. Okay, same drug, same dose, completely different outcome you will be having. So that is what the meaning of the percentage of time of the free drug that should be greater than MIC. Okay, intermediate bolus levels falls below MIC, extended infusion sustain the exposure, right? So I elaborated this two bullet point in a very simple way, that if piperacillin tazobactam is given as a short bolus, that drug levels, that may fall below the MIC before the next dose. So by giving the same dose as an extended infusion, what will happen? We can keep these levels above the MIC. That is what our principle is, right? So above MIC, we need to keep it. So same drug, same dose, but completely different outcomes. So that is what the concept, the example is. Now, the next parameter we need to understand is Cmax and MIC ratio. Okay, Cmax to MIC ratio. So that is referring to how high the peak concentration is relative to the MIC. Again, I'm repeating, how much high the peak concentration, C max means maximum concentration. The peak concentration is relative to MIC. That is the ratio, minimum inhibitory concentration. So this applies to concentration dependent. That this was time dependent, guys. Now the C max to MIC ratio is the concentration dependent, antibiotics, such as, I will say examples, aminoglycosides, daptomycin and all. So this principle is very simple. Higher the peak, equals to the better killing. Okay. Higher peaks equals to the better killing. So once daily high dose is preferred, C max to MIC ratio. Okay. So that you must be clear with. We have example to understand it. See, C max to MIC example. So with the, I will say the gentamicin. Here the gentamicin is written. So let me just give you idea about the gentamicin. With gentamicin, multiple small doses produces low peaks, guys. Multiple small dose of gentamicin, if you are introducing, what will be having low peaks, okay? Produce low peaks and also the resistance in the patient. So once daily high dose of gentamicin produces a high peak, that is the C max, okay? Rapid bacterial killing will be there and less resistance will develop. So this is why we say hit hard and then stop. Okay, hit hard and then stop. So Cmax to MIC ratio is like that. Higher peak, better killing and less resistance. Gentamicin once daily dosing is the example to understand Cmax to MIC ratio. Okay, small dose is not enough for gentamicin cases, right? Next, you need to understand the AUC, that is the area under the curve, to MIC. Okay, AUC to MIC, that represents the total drug exposure over 24 hours relative to minimum inhibitory concentration. Right? So this is the area under the curve. Area under the curve means total drug exposure over 24 hours. So this applies to the drugs like fluoroquinolones, vancomycin, linezolid and all. So here both like dose and duration both matters. Okay, dose is also matters and duration is also matters. So this is again very important. Let me just give you idea about examples related to the AUC. So let's just have the example of vancomycin. Everyone is aware of the vancomycin. So vancomycin, for this particular drug, the target of the AUC to MIC is 400 to 600. The AUC MIC target. Through only monitoring, here it is written that through only monitoring is inadequate. So through only monitoring, this does not accurately reflect the exposure, I will say, and it may lead to the nephrotoxicity as well, because vancomycin is a nephrotoxic drug, right? So this is why modern stewardship emphasizes further AUC based monitoring. We need to do area under the curve based monitoring. So these are the three very important factors I will be discussing up to next 2 weeks, I guess. In next upcoming two sessions, we will be discussing about pharmacokinetic and pharmacodynamics. And these three, okay, these three, T should be greater than MIC, Cmax to MIC and AUC to MIC. We will be discussing these things thoroughly in detail in our upcoming sessions. Okay, so today just understand we will be we are just started it, right? So understand PK and PD, we need to discuss a lot of things related to it. Majorly these three indices, I will say, these three parameters, I will say, we need to briefly discuss about it. Future clinical pharmacists should be ready with these principles to apply modern stewardship principles in the practice, right? So this is just the introduction of it. We need to discuss a lot of things in it, right? Now, what is tissue penetration? What are the hidden failures which are further leads to the resistance and all? So, adequate blood levels do not guarantee the adequate levels at the site of infection, guys. So that is also one of the factors to consider. Poor penetration occurs in lungs, central nervous systems, bones. Abscesses will be found. So this is the hidden cause of the treatment failure. Sometimes what happen, this is also the reason behind the treatment failure. Adequate serum, adequate site level. So you need to understand that this can be also the another reason behind the treatment failure. I will let you know in the clinical relevance that what is the reason and what is the link between these things. Okay, we have again example to understand this for the poor penetration. See, here we have the example of the daptomycin. So daptomycin has poor lung penetration capacity. Also, we have aminoglycosides. So the aminoglycoside penetrate very poorly into the CNS. Also, we have colistin. Colistin has also unpredictable, tissue distribution. So serum MIC, that alone is not enough. If we are aiming that we need to make the minimum inhibitory concentration into the serum, but it is not enough because some of the agents are very having a very poor tissue penetration because of their chemical moiety, because of the structure. So we need to be aware of this thing also when we are handling the resistance cases, because this might be also the reason. Okay, also we need to understand about the ICU physiology changes. Okay, ICU physiology further alters the whole pharmacokinetic profile. So in ICU, the critically ill patient will be there. So what will happen in critically ill patient? Pharmacokinetics change dramatically. I hope you guys are aware of this thing, right? So in the ICU patient, in the critically ill patient, this PK parameters are changing dramatically. Okay, very different. So there is increased volume of distribution you will find due to some capillary leak and all. So that second bullet point, right? Or else you will be having hypoalbuminemia also, that alters the free drug level because we need that. Okay, albumin, we need it. So that will again, we will be having a free drug level, toxicity risk will be there. Organ dysfunction affects also the clearance. Okay, so in ICU, I will be more focused towards, because that's where exactly you need more precision. Standard dosing यहाँ पे काम नहीं आएगा, right? Standard dosing often becomes inadequate in these cases because of dramatically shifting pharmacokinetic profiles in the ICU patients. So that also we need to be aware of. And we need to have the dosing optimization strategies with us. So to overcome this all the issues, we use certain tools, right? We use like loading doses, we use extended infusions, extended or continuous infusions, right? Also we use therapeutic drug monitoring. I already told you the narrow therapeutic index drugs. Okay, so we already have indexation for the drugs, right? We have minimum inhibitory concentration, maximum safe concentration, and the range in between is the therapeutic window or the therapeutic index. And those drugs don't have much of the gap in between of MIC and MSC, so that will consider as a narrow therapeutic drugs. And those drugs having a narrow therapeutic index requires TDM. We need to do a continuously therapeutic drug monitoring. We need to check the serum level, the plasma level of the drug continuously in the body, so that it can be, it can show the effect. That is what the TDM is. And for TDM, we have lots of, calculation and all. We will discuss later this thing, but you must be aware of these are the dose optimization strategies we are using. Okay, so we will discuss these things in detail also. Let's discuss about extended infusion. So I will be briefing you about it because many people, many students won't be able to understand what is extended infusion concept. Okay, so that's the reason I have included two slides for extended and continuous infusion. What do you mean by extended? So extended infusion, that means administering the antibiotic over 3 to 4 hours instead of 30 minutes, guys. Okay, instead of 30 minutes, extended infusion means administering the antibiotic over 3 to 4 hours. Okay, यहाँ पे लिखा हुआ है, it is mentioned here, 3 to 4 hour infusion instead of 30 minutes. So this improves what? The T. Okay, the percentage of the free drug, the time of the percentage of the free drug will be greater than the MIC. We need to follow this principle. So to do this, what we can do? Extended infusion. So we will be having a very, very small dose, and we will be having an extended period. Right? So we will achieve this very first concept, that is the T should be greater than MIC. So this improves T greater than MIC without increasing the total daily dose. So, for example, if the patient intended to get the 40 mg of particular drug, and we need to maintain this T greater than MIC, what we will do? We will do extended infusion. We cannot go beyond 40 mg. But if the situation is like that, okay, we need to do a extended infusion for to improve this T greater than MIC, to match this particular phenomena, right? So that is the reason why we use this technique. We will be having the same dose infusion for 3 to 4 hour long rather than 30 minutes. Okay, that is extended infusion. Next, we have continuous infusion, the terminology. And continuous infusion maintains a constant drug concentration above the MIC. What do you mean by continuous infusion? So that is maintaining the drug concentration about about what exactly we require to kill the organism. That is the minimum inhibitory concentration. For example, 30 mg is required to kill the bacteria. So we will be maintaining 35 mg, continuously in the body. That is continuous in the plasma or serum. That is continuous infusion, right? So continuous infusion maintains a constant drug concentration above the MIC, and it is, especially useful in the cases of severe sepsis and also the infections with the high MIC, organisms, MDR pathogens. So this is the continuous infusion. You must be aware of these terminologies when we are diving deep into the concepts. Okay. We have the sepsis case here to discuss. So see here, 55-year-old male present with the septic shock, okay, and also the acute kidney injury, the AKI. So he is started on the piperacillin tazobactam, and he will be started on the continuous infusion. So in cases like this, the continuous infusion, that is being administered. So you should be able to understand in which scenarios which type of infusion is there. Okay, to understand the stewardship principles, to understand PKPD principles, we need to deep dive. We need to deep dive in every concept, and that is the reason why I am elaborating every terminology to you today. Okay, so what is the intervention? So intervention with the intermittent bolus dosing, I will say clinical response is poor, right? Intermittent bolus will fail. So switch to extended infusion in that case. Continuous infusion or extended infusion will be your, uh, you know, um, choice. Okay. So what will be the outcome here of the case? After extended infusion, your hemodynamics will improve. Okay. Your infection control improves, and also no dose escalation is required further. You don't need to do a escalation of the dose, but you can maintain it thoroughly, and you can maintain the very first principle, that is T should be greater than MIC, right? So that you need to have in, you can have in mind that we need to follow that principle. And also we have renal replacement therapy impact here. So renal replacement therapy alters further the clearance and the half-life of all of the antibiotics, right? So both, underdosing and toxicity are at a risk. Renal replacement therapy alters the clearance and half-life. And in this particular cases, you will be having the under-treatment risk and also the toxicity risk. So in this case, individualized dosing is mandatory. Individualized treatment personalized therapy, precision therapy is mandatory, right? We cannot have the traditional prescribing pattern in this particular scenarios, right? So this is how PKPD starts. This is how kinetics and pharmacodynamics starts. And now, upcoming 2 to 3 sessions, we will be diving deep into these principles, guys. Okay. See this ECMO and antibiotic dosing. You must be aware of this thing. So, in the extracorporeal membrane oxygenation, the term, okay, I will be giving you the full form of it. It is the extracorporeal membrane oxygenation, also known as ECMO. Drugs that, that may be I will say, sequestered in the circuit. Okay, so in this scenario, what happens that this drug sequestration in the circuit. So higher loading doses and close monitoring are required in this particular scenarios. If you are not getting this point right now, don't worry. In upcoming 2 sessions, I will be elaborating each and every point, but today is the introduction of PKPD concepts in the antimicrobial stewardship, and we actually started from the very base today, right? So very base, I mean, see, if you have aim to cure AMR and antimicrobial resistance, you must be aware of the pharmacokinetic and dynamic profiles, and that is where exactly we have started, though it is that advanced version. So I am little bit on an advanced level, but if you found difficulty in any of the terminologies, because it is the advanced version, many of you are new to this course, you can drop me a message on the WhatsApp, or you can directly connect, also personally to solve your queries, because those who have attended the basic things, they might be aware of this terminologies. Those who are new to this course, might be this terminology is new for you. Okay, so we can solve at the end your all the questions and queries, and you can personally also text at any time. Okay, so do not worry. But for now, just understand these are the concepts we will be diving deep into further. Okay, so this is the end for today, and key take home messages for today is stewardship fails without PKPD, and that is the reason why we are deep diving towards the PKPD principles. Okay, same dose, same exposure. Same dose does not mean always the same exposure, guys. Okay, so it is, we need to understand this thing. And ICU patients demands individualized dosing. I will let you know why I am always focused towards ICU, because in this particular area you will be finding lots of AMR cases. Okay, MDR, XDR, and PDR, and that's where exactly you can save lives if you know the concept, if you know how to deal with it. Okay, so you must be aware of. Final message for today is antimicrobial stewardship is not a restriction. It is not like we need to withdraw some of the unnecessary drugs, we need to manage polypharmacy. Aisa nahi hai, it is not like that. It is the precision medicine, guys. Okay, it is precision, and it is precision medicine. It is aiming for individualized treatment. It is aiming for precision medicine, personalized medicine. Okay, but how you can do it? If you know the concept clarity of pharmacokinetics, pharmacodynamic profiles. Okay, and we will be diving deep into this matters. Okay, so don't worry if you if some of the terminologies are new for you. Don't worry, I think I can show you also what is coming into our next 3 to 5 weeks. I will elaborate, but first we will be taking your okay. Let's have a look on the questions. Very first question I can see. Explain once the concept of, see, this AUC to MIC. We will be diving deep into our upcoming sessions. So don't worry if you are not taking this concept right now. Just understand that these are the base. Okay, these are the very basic things we need to cover. Okay, when increased volume of distribution, as I earlier told you, know the capillary leak and the internal damages are happening. So that is the reason behind the volume of distribution is large in the ICU conditions. Extended versus continuous infusion, continuous confusion. Okay, if you have doubt, please elaborate your question so that I can give you answer. How to do extended infusion? The method is the same. See, there is a slight and thin line difference between these two different things. Okay, extended infusion and the continuous infusion is different, and the difference is there. I will also, I already give you the the examples also for the continuous infusion and the extended infusion. Extended infusion means you are extending the period. Okay, you are extending the time, administering the antibiotics over 3 to 4 hours instead of 30 minutes, while continuous infusion meaning that maintains a constant drug concentration about the MIC. It is not exact opposite terms, guys. Simultaneously it works. Okay, if you are doing extended infusion and also maintaining a concentration about MIC, you are following the both at once also. Okay, don't take it as in opposite terms. Okay, I think a lot of people has that question. I hope it is making sense now. It is not like opposite term, guys. Okay, extended infusion means administering antibiotic over extended period of time, like 3 to 4 hours instead of 30 minutes. While continuous infusion is something like it shows it is making the concentration in the plasma, which is above MIC continuously, right? Both of the term has the meaning. How renal replacement leads to overdose? Renal replacement therapy that alters the clearance and the half life, clearance rate, because 90% of the drugs are being excreted from the renal route. So it is directly altering the clearance and the half life of your antibiotics, whatever you have expected, which you will not see in this particular cases. That is how it affects the dose. Okay, and you will be having the risk of under treatment also, and the toxicity as well in this case. Is there any guidelines for the duration of antibiotics? As for the, yes, and guideline, I think in the curriculum we have the separate session on the guidelines. So don't worry, it is coming. Okay. Just as I earlier told you in the introduction itself, focus on the basic today. We will be having everything. Okay. It is coming. It is coming. You said continuous infusion is better choice of treatment in the case of sepsis, but when you explain case, you explain switching to extended infusion. As I earlier told you, the difference is you are taking this both of the term as an opposite, guys. It is not opposite. The term itself has the meaning in it, and it is completely depend on the case itself. What is the scenario? Okay, and then it is being decided that we need to maintain in septics. What happened a lot, septic का मतलब ही यही है ना, no, the meaning of the septic shock is a lot of infection is there, right? So we need to maintain a continuous infection, continuous infusion, right? We need to maintain the drug concentration about minimum inhibitory concentration which is required to kill, right? So we need to maintain it. Continuous infusion is maintain, it is very important for in the sepsis cases. Okay, but if you are using certain antibiotics, okay, certain antibiotics which are particularly narrow spectrum, and some antibiotics which are further, I can say, a narrow spectrum, right? So you are doing a de-escalation after the culture reports and you are focused towards the main antibiotics, then in that case you can follow the extended infusion, so that you can maintain the MIC throughout the time, and also at the same time you will be having the extended infusion. That is what the meaning is. Some studies have been published stating that in the patients with influenza along with an antiviral, antibiotic can also be administered to reduce the, yes, respiratory associated hospitalization. Yes, of course. See, this is the cases in the critically ill patients. Sometimes this both can be administered simultaneously, but it is very the rare scenarios. But people are doing for the treatment failure risk. That is what the wrong. Okay, that is that is situation is wrong. Dengue is the viral disease, still doctors are prescribed, and that is the reason behind the resistance, no? But still, see, for the dengue case, I will say that ceftriaxone and all are proven effective. Okay, proven effective therapies. Though we don't have any cure for dengue till date, we are only preventing it by using ceftriaxone injections and all, right? We don't have exact cure of the dengue till date. We are only preventing the symptoms in these cases. How can de-escalate from continuous infusion to extended or switching antibiotics? See, it is completely depend on again the scenario what you are facing, that how to do a de-escalation from the continuous infusion to extended. I will tell you there are certain techniques, as all I already mentioned, that whatever principles we have been discussing today, I will be elaborating each and every point in our upcoming sessions. So we will be diving deep into every matter. So you will be having idea. Okay. If I want to discuss this right now to, how to de-escalate from continuous infusion to extended, I need again and half an hour to discuss this thing. So these are the things which are coming in the future, guys. Be a little bit, have little bit patience. Okay. Can I know which specific antibiotics you are referring to in here, dengue cases? As I earlier told you, we don't have the exact cause for the dengue, right? In many cases, I have seen in the dengue, ceftriaxone is prescribed, okay, and ceftriaxone injections are being prescribed for the fever. Again, paracetamol and the Dolo 650, and those are the tablets which are being prescribed in the discharge medicine, right? And in the IV, if the patient is admitted for the platelet and all, they are doing continuous monitoring of the platelet, and they are also suggesting some of the non-pharmacological interventions for the dengue cases, right? Just continuous infusion will go for a whole day. So, I will say no, not a whole day, but we can maintain in between. Okay. No, if we are giving meropenem extended infusion over 3 hours, then it is in continuous infusion over how many hours? See, it is not like that. I will tell you some of the very good example of extended and continuous infusion in our upcoming sessions. Okay, we will be diving deep into each of the principles and how it is related to the stewardship. Okay. As per my knowledge, related replacement therapy, it means dialysis. Kindly confirm how come it leads to overdose. This is actually needed to function opposite, right? To prevent overdose or see, renal replacement. Of course, it is dialysis only, but what I need to tell you is renal replacement therapies alters the whole clearance mechanism and the half life of your antibiotic. What you have expected, it is not as you expected in the this patient. So that is the point of view of telling you that you need to be very precise while handling this patients, right? And we need to think it in a very different way while we are handling the renal replacement cases. So here is the cases of underdosing and toxicity. Toxicity risk is higher, okay, in this particular cases. Heads in case of sepsis written in diagnosis and ICU patient organism came sterile and CS sent before antibiotic administration. Is it possible in case of sepsis? Yes, it is possible. Yes, it is possible, and but the rare scenarios, obviously, we will be having a sepsis in ICU cases, and particularly sepsis case example. Throughout our learning of PKPD, I will be having the sepsis example to understand, because it is in this particular scenarios where MDR, XDR, PDR are very large. So I will tell you how exactly it is happens, right? I will be taking sepsis cases throughout as an example. What if the patient needed continuous infusion and had renal impaired too? In that scenario, continuous monitoring is required. Okay. And exactly, we need to check the renal impairment stages as well. We had the formulas to calculate the dose for renal impairment patient. Okay. For hepat and renal, we have formulas to calculate the doses, guys. we have Cockcroft criteria, we have lots of things. And renal impairment के भी stages होते हैं, right? We have stages of renal impairment. We need to check, we need to correlate with the stage that what amount of dose a patient can tolerate. And based on that, the therapy is being guided. Giving all multi-drug resistant drugs like Polivy, everything. How can we tell this in this continuous or extended infusion? I will be taking this particularly, in our this session, which is called. I think you have seen the brochure or not. I am not sure, but please check your module number 2, which is Advanced Microbiology for Clinicians, week 3 and 4, and we will be discussing these things in very, very detail. Okay, these things are coming. We will be focusing on the module number 2 from our next week, which will focus on the rapid diagnostics, genotypic resistance, detection, WGS. Also, I will discuss advanced culture interpretations, breakpoints, okay, effective lab clinician collaboration. Also, we will discuss how to do it. So, बहुत सारी चीजें हैं जो कि हमें अभी डिस्कस करनी है. दिस इज ओनली द फर्स्ट लेक्चर एंड दिस इज द you know just the concept clarity about the PKPD, what we need to understand before deep diving into the microbiology and the syndromic stewardships and all. You can check the brochure, guys. We have all the things in the brochure, all the things we will be going to discuss. Okay, I hope it is clear to you and making sense. Okay, and I will be advising also go and check once the brochure so that it will give you idea what is coming in the next week, next to next week and all, so that step by step you can build your base. Step by step you can go forward, right? Still, if you have any question, query, doubt, confusion, you can drop the message in the WhatsApp. Okay, the group is for us only, and you can direct personally also you can connect if you have any doubt. I am just a message away. Okay, okay, so if there is no question, I think we can wind up for today, and see you guys on next Thursday. Okay, thank you so much for joining today. Thank you.